माननीय ग्रामी बहुत सीनियर प्रोफेसर हमारे सलीम साहब, जावेद चौधरी साहब हमारे कोई 50 साल से मेरे साथ हैं, ये पिछले से ख्वाजा साहब और मेरे सारे कोलीग स्टूडेंट्स, आई extend a very warm welcome to all of you. It is a wonderful day. We are here to have a presentation of 4 of our colleagues on various topics. Theme is uveitis. Will be followed by our national speaker on non-infectious uveitis and another international speaker on latest trends in central retinal vein occlusion. I will start the session with the name of Almighty Allah. I will call Jasm Saab, Hafiz Jasm Saab, to come over the dais and recite Holy Quran. Thank you.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. صدق الله العظيم. पढ़ अपने रब के नाम से जिसने तुझे पैदा किया, जिसने इंसान को खून के लोथड़े से पैदा किया। तो पढ़ता रहे, तेरा रब बड़ा करम वाला है, जिसने कलम के जरिए इल्म सिखाया और जिसने इंसान को वो कुछ सिखाया जिसको उसका इल्म नहीं था। सदक़ल्लाहुल अज़ीम।
Jazakallah. Now I will invite Dr. Khaja Khalid Saib, who is representing General Secretary. He himself is a Joint Secretary. General Secretary is abroad for a conference. So Dr. Khaja Khalid Saib will represent our General Secretary, and I will request him to come over the dais and start the session.
Stage secretary कौन है? Thank you very much, Sir Professor Abdul Mujid Saab, for a collaborative meeting of OSP and Fatima Memorial Hospital. I have stayed in this medical college for 1 year, so yeah, I feel like at home. So excellent. Dr. Fatima will be conducting the session, so I invite her straight away so that we can start the proceedings.
Assalamu alaikum. I welcome you all in Fatima Memorial Hospital, and we will start our session with the presentation of Dr. Anam. She is our senior registrar, and the topic is enjoyed streaks. Thank you. Aaj Dr. Anam. लाइट ऑफ करते थोड़ी सी, लाइट ऑफ करते थोड़ी सी, एक लाइट चलती है ए वाली 1 वाली, मैं इधर नहीं है वहाँ से फर्स्ट ऊपर सबसे डॉक्टर अनम। हाँ हाँ, लाइट ऑफ कर दो। लाइट ऑफ करना पीछे बंद करना।
अस्सलाम वालेकुम। I am Dr. Anam, working as Senior Registrar at FMH Hospital, Lahore. Today I am going to present an interesting case. A 40 years old married female resident of Manga Mandi of low socioeconomic status was presented to us in OPD with a history of decrease of vision in both eyes for the last 2 years. The decrease of vision was gradual, painless. It was associated with seeing distorted images. There was no history of flashes, floaters, or any significant related symptoms. The patient vision slightly got improved on wearing spectacles. In past ophthalmic history, the patient stated that she visited a charity hospital about 1 year back and she had intraocular injections in both eyes 1 month apart. Her vision got improved and then she lost the follow-up. The family history was insignificant. There was no specific history of any ocular or systemic disease. In systemic history, the patient noticed increased wrinkling of skin over the neck for the last few years, which she thought was due to advancing age. The rest of the systemic history, including gastrointestinal tract and CVS, was unremarkable. On
This
ocular
conference will
examination
now be
revealed the visual
recorded.
acuity in the right eye was 618, while in the left eye it was 660. There was no significant improvement on doing refraction. The intraocular pressure was 19 millimeters of mercury in right and 18 millimeters of mercury in the left eye. The anterior segment examination was unremarkable except patient had mild lenticular changes in both eyes. This is the posterior segment examination of the right eye as depicted by the color fundus photograph. As you can see, there are numerous grayish-white lines which are extending outward from the optic disc, signifying angioid streaks, and there is a subretinal scar situated supranasal to the fovea with altered foveal reflex. There are multiple areas of well circumscribed chorioretinal atrophy. This is the superior periphery of the right eye as depicted in this picture, and there are multiple pinpoint chorioretinal atrophic areas and with the tail-like configuration signifying comet tail lesions as seen in angioid streaks related with pseudoxanthoma elastica. This is color fundus photograph of the left eye. There are again angioid streaks and a subretinal scar at the fovea and multiple comet tail lesions in the superior periphery of the left eye too. This is the red-free photograph of the right and left eyes, again depicting the same clinical findings as I have described earlier. This is the fundus autofluorescence image of the right eye. As you can see, the angioid streaks have become more prominent and there is subretinal scarring, most probably signifying choroidal neovascular membrane. The same findings are seen in the fundus autofluorescence image of the left eye. This is the CNV membrane, these are the angioid streaks, and this is the RP abnormality areas. This was the dermatological examination of the patient. As you can see, the skin has increased redundance, there is laxity. Along with that, there is multiple pigmented papules over the center of the neck, which is a plucked chicken appearance as noted in pseudoxanthoma elasticum. The systemic examination was unremarkable. Our differential diagnosis was were pseudoxanthoma elasticum with angioid streak, Paget disease with angioid streaks, lateral cracks in high myope, and choroidal rupture. The last two were ruled out as the patient was not high myope or there was no significant history of ocular blunt trauma, and these two entities are morphologically different from those lesions seen in angioid streaks. Investigations, we did ocular as well as systemic investigations. Ocular investigations, we did OCT and OCT angiography. This is the OCT picture of the right eye. There is increased central macular thickness and multiple hyporeflective cystic spaces in the juxtafoveal area. There is a subretinal hyperreflective lesion with disruption of the outer retinal layer in the choroid. So it signifies type 2 choroidal neovascular lesion. This is the OCT picture of the left eye. There are multiple hyperreflective cystic spaces noted with increased thickness in the central macular area along with the juxtafoveal area with again type 2 choroidal neovascular lesion. This is the OCT angiographic picture of the right eye. As you can see, the neovascular membrane has extended up to the outer retinal slab. Again, in this picture, the neovascular membrane can be seen extending up to the outer retinal slab. Our systemic investigations were complete blood count with peripheral smear to rule out other causes of enjoyed streak as thalassemias and sickle cell anemia. Serum alkaline phosphatase and serum electrolytes were also in the normal range, which rule out Paget's disease. Our provisional diagnosis was pseudoxanthoma elasticum with enjoyed streak and CNV. The treatment involved multi-systemic approach. The patient was referred to dermatologist for further evaluation, and we also consulted the gastroenterology department, and patient was also referred to cardiologist for further evaluation. For CNV, we advised bilateral intravitreal anti-VEGF. This is the OCT picture after first intravitreal Avastin. The CMT has improved and there is decreased number of hyperreflective cystic spaces as evident in this picture. The same findings are observed in the left eye, decreased number of hyperreflective cystic spaces and central macular thickness. And the patient also noted subjective improvement in the visual symptoms. A short discussion on enjoyed streaks. Enjoyed streaks are basically crack-like dehiscences in the Brooks membrane with atrophy of the retinal pigment epithelium and photoreceptor layer. They lies deep to the vessels. There are multiple mechanisms to explain the pathology of the enjoyed streaks. There is abnormality of the fibers of the Brooks membrane. Along with that, there is increased tendency for the deposition of the metal salts. This results in brittleness of the Brooks membrane, and ultimately it is prone to the rupture and formation of the neovessel. Multiple conditions are associated with enjoyed streaks. The most common systemic association is pseudoxanthoma elasticum. Others are Paget's disease, hemoglobinopathies, hereditary spherocytosis, and senile elastosis of skin. Pseudoxanthoma elasticum is an inherited disorder, and the inheritance is most commonly autosomal recessive. There is abnormal elastogenesis in the body with increased deposition of calcium salts in the cardiovascular system, in the gastrointestinal system, in the eyes, and in the skin. Diagnostic criteria, there is definitive diagnostic criteria. It is characterized by ocular findings, which states enjoyed streaks or poor the orange appearance in an individual less than 20 years of age, together with the skin findings. Skin findings include plucked chicken appearance, and along with that there is diagnostic histopathological changes in the skin, which includes calcified elastic fibers in the mid and lower dermis, which is confirmed subsequently by the positive calcium stains. The complications which can occur in enjoyed streak, the most common is choroidal neovascularization. So if a patient presents to you under 50 years of age and has bilateral CNV, you should see for enjoyed streaks and its related systemic associations. And other complications are choroidal rupture and foveal involvement by a streak. These are the causes of basically decreased visual acuity in these patients. The treatment involves multisystemic approach. We should rule out systemic cause. We should treat ocular complications. We should advise the patient to avoid contact sports and trauma, as there is increased risk of scleral rupture. And the patient is asked for regular follow-ups and monitor with Emsler grid if there is no CNV, and asked to return immediately if any change in the VN or the symptoms reported. Thank you.
Any questions or comments, please?
Thank you. Now I would like to call our second presenter, Dr. Hamza Nadeem. He is working as a medical officer in our unit, and his topic is uveitis and Behçet disease. Okay, to Hamza. ये लगा अबे जैसे
Assalamualaikum everyone. My name is Dr. Hamza Nadeem. I'll be continuing with next presentation of ours. We'll start with the history now. A female 45 years of age, resident of Iqbal Town, Lahore, presented in our OPD with complaints of decrease of vision in both eyes for the past 1 month. On further inquiry, she told us that it was gradual in onset. Her visual loss was painless. It was associated with seeing distorted wavy images, but there were no floaters or flashes. Visual loss was more severe in right eyes compared to the left eye, according to the patient, and her vision didn't improve by spectacles. So, on further inquiry on the past medical ophthalmic history, she told us that she has had anterior uveitis for the last 10 years, and she was diagnosed and treated in a tertiary care hospital. Ever since then, she has had multiple episodes of anterior uveitis, each time leading to a hospital visit, and the latest one being 1 year ago. In her past surgical ophthalmic history, she told us that she had had bilateral cataract surgery 7 years ago, and there are no history of ocular injections or any laser treatment to the eyes. In her family history, there were no specific history of any ocular systemic disease. Coming to the past medical history, a patient told us that she has been diagnosed with Behçet's disease or Behçet syndrome for the past 13 years now. She was under treatment for it in the rheumatology department of FMH, but she lost her follow-up 10 months ago. Coming to the systemic history, she told us that she has had multiple ulcers and scar marks on her upper and lower limbs. There were also multiple ulcers in her genital area as well. In general physical examination, she was a middle-aged woman with stable vitals. Now coming to the ocular examination, her visual acuity on the right side was 6/60, and on best corrected visual acuity it improved only to 636. On the left side it was 6/12 and it didn't improve on best corrected visual acuity. Her IOP on the both sides were normal. Coming to the anterior segment examination, as you all can see that here both eyes are pseudophakic. On the right side you can see that there are posterior synechia starting from the 5 o'clock position all the way to the 10 o'clock position. Anterior chamber was quiet and there were no cells noted. So we advise her FFA and OCT after seeing the fundal pictures. Here are the fundus, as you all can see. They show the abnormalities. On the right side, the macular area of the right fundus shows that there are edema, exudates and hemorrhages on this side. And on the left side, you can see that there is perifoveal edema here. And these findings were confirmed on the FFA as well. Coming to the OCT, the right eye OCT wasn't clear because of the vitreous haze which was present in front of the macular area. So we have the picture of only the left eye. As you all can see that there is perifoveal edema on the temporal side, and there are deposits in the deeper layers of the retina as well. So here is the picture of the examination of the mouth of the patient. There were multiple oral ulcers, which are basically aphthous ulcers that are a hallmark of Behçet disease, and there were ulcers on her genital area as well, but she didn't allow us. She didn't give us the consent to take the picture of it. So coming to the other investigations, apart from the OCT and FFA, we advise her the complete blood count with peripheral smear that showed iron deficiency anemia, and her inflammatory markers were also done were within normal range to rule out other causes of these signs. So coming to the provisional diagnosis, we diagnose her as maculopathy in Behçet disease. For that maculopathy, bilateral suprachoroidal triamcinolone acetonide injection was advised to the patient, and she was asked for regular follow-ups. Apart from that, as this Behçet disease is a multi-system disease, so we advise her, we referred her to the rheumatology department for further evaluation and treatment for the Behçet disease as well. On giving these injections, she was called on regular follow-ups, and her vision improved and it showed wonderful recovery. On the right side, it improved from 6/60 to 6/12, and on the left side, it improved from 6/12 to 6/9. So here is the picture 2 months after the injection. As you all can see that on the right side, there is significant improvement in the edema, exudates and hemorrhages that were present in the macular area. Here is a picture of the right side after the injection. Unfortunately, we don't have the picture before the injection because of the causes I already told you. And on the left side, you can see that there was perifoveal edema with the deposit in the inner deeper layers on the left side. And after the injection, it improved significantly here as well. So now coming to the pathophysiology of maculopathy, it is basically retinal thickening of the macula due to the disruption of the normal blood retinal barrier. This causes leakage from the perifoveal retinal capillaries and accumulation of fluids, exudates and hemorrhages within the macula. So here is a picture that shows us the range of acute anterior uveitis that can occur in Behçet syndrome. As on the left side, you can see that there is anterior uveitis along with the hypopyon, and the hallmark feature of the hypopyon of Behçet syndrome is that its position changes with the change in the head position as well. And on the right side, you can see that there is hypopyon as well as pupillary membrane is also there. There is corneal haze as well, and there is hyperemia and congestion on the palpebral and the bulbar part of the conjunctiva as well. So basically, what is Behçet syndrome? It is an autoimmune disorder leading to vasculitis and inflammation of different tissues. Many cases are sporadic, and a small percentage of cases have been reported to run in the families, but there is no clear pattern of inheritance of it. So diagnostic criteria varies according to many books, but the most widely used criteria is International Study Guide for Behçet disease. This criteria tells us that Behçet disease is a clinical diagnosis. There is no specific test that can tell us about Behçet disease. This criteria includes mouth ulcers, which are recurrent at least 3 times in the last 12 months, and any of 2 of the following to be present to be diagnosed as Behçet disease. Genital source can be there, eye lesions of any kind, anterior uveitis, posterior uveitis, retinal vasculitis, all the features of the eye. We only need one here, and there can be certain skin lesions as well, and positive result on pathology testing. So basically these 4, we need any 2 along with the mouth ulcers to diagnose it as Behçet disease. Here's a picture of the international study group criteria, and it's basically the same that I have already mentioned. The thing to be noted is that Behçet disease is a diagnosis of exclusion. For all the skin lesions, eye lesions, and all the ulcerations, we need to rule out infections and other causes. After they are ruled out, only then we can say that this is Behçet disease. If there is any cause of these ulcers, then we have to say that it may or may not be Behçet disease. Coming to the ocular findings in Behçet syndrome, it varies, but the most common is recurrent acute anterior uveitis, and this was the case with our patient as well. And there can be retinal infiltrates there can be retinal vasculitis, there can be vascular leakage, which was also present in our patient. There can be vitritis. Rare findings can include conjunctivitis, scleritis, or episcleritis. Coming to the complications, meningitis can be there, which is also known as neuro-Behçet syndrome. Blindness can occur because of the retinal vasculitis and the changes in the retina that happens. Stroke can also occur because of the problems with the neuro-Behçet syndrome. Thank you.
So good presentation, fairly rare disease, usually undiagnosed. So where the disease is common, in which region of the world? In Turkey. Okay.
It comes from the Turkey actually.
So it is in the Mediterranean region, the disease is more common. And the Behçet is Turkish name, so it is pronounced in different ways. You see, so what differential diagnosis have you considered?
So in this case, as it was already diagnosed as Behçet syndrome, we basically treated her for her maculopathy. And if we go only with the ocular findings of Behçet syndrome, then we can look upon other causes. Like in case of retinal vasculitis, we can see other infections or sarcoidosis, or in retinal infiltrates, we can see some kind of viral infection on the retina as well. So basically in this case, the diagnosis was already provided to us by the patient, and we only treated her for her maculopathy here.
So my humble suggestion is that you never accept the diagnosis made by others. you have to make your own diagnosis. You have to consider the history, examination, and investigations and reach your own conclusion and then treat. Never take the other's word for taken. You don't take for granted the diagnosis. So you always consider differential diagnosis before advising investigations and treatment. You have to make a list of the diagnosis. You keep the diagnosis which has been offered by others at the top maybe, but you have to consider the other differential diagnoses before you finalize the diagnosis. So this is my suggestion.
Yes, sir.
In the previous presentation, that was also a good one, a rare disease and pseudoxanthoma. I remember a word, plucked chicken appearance. So what is a plucked chicken? Anybody? जो टर्म्स हम पढ़ते हैं ना उनका मतलब जरूर देखते हैं. जो हम पुरानी आदत थी इंग्लिश की बुक में डिक्शनरी से देख के हमने मीनिंग लिखे होते थे. सो सूडोजैंथोमा इलास्टिकम में प्लग चिकन अपीयरेंस का वर्ड होता है. प्लग चिकन का मतलब क्या है? तो जो जहां कढ़ाई बनाते हैं ना वहां पे आप देखें तो मुर्गे लटकाए होते हैं, उन्होंने खाल उतारी होती है. सो विदाउट स्किन जो चिकन होता है उसको कहते हैं प्लग चिकन अपीयरेंस. और सूडोजैंथोमा इलास्टिकम में वो होती है माइनस स्किन जो है. सो एक और मैं सजेशन जो देना चाहता हूँ, ये सारे टॉपिक्स अच्छे हैं कि रेयर हैं. मैंने पहला इसमें जो खोल के देखा Behçet's disease in Pakistan, the first article which I encountered was an article from Fatima Memorial Hospital in 2019. So whenever you present a case, you always come up with the references. और उसमें बुक्स तो खैर जरा पुरानी होती है, तो जो आर्टिकल्स होते हैं वो जरूर देखें कि आपके डेमोग्राफिक डाटा क्या होता है, किस एज में ज्यादा कॉमन है, किस सेक्स में ज्यादा कॉमन है, किस रीजन में रेस में ज्यादा कॉमन है. सो हर डिजीज में पहले ये चार चीजें आती हैं, सेक्स, रेस, एज, किस व्हाइट्स में ज्यादा है या ईस्टर्न कंट्रीज में ज्यादा है. देन यू सी द लेटेस्ट आर्टिकल कि हमारे यहाँ हमारी कंट्री में क्या रिसर्च हुई. फातिमा मेमोरियल हॉस्पिटल में जो बेशेस डिजीज पे आर्टिकल है, 20 केसेस उन्होंने डिस्क्राइब किए. वंडरफुल. So thank you very much.
Thank you so much.
I would like to say something.
Yes, sir.
That was the presentation इसमें जो चीजें हैं, keep in mind for all of you, this is one of the few conditions which involves both arteries and veins.
Yes, sir.
Okay? It is one of the few conditions.
Yes, sir.
और डिफरेंशियल डायग्नोसिस में जितनी भी जो वेस्कुलाइटिस वाली चीजें हैं वो सारी की सारी आएंगी, इंक्लूडिंग सार्कोइडोसिस, सिफिलिस, ट्यूबरकुलोसिस एटसेट्रा एटसेट्रा.
Yes, sir.
द सेकंड थिंग इज यहाँ पे ज्यादातर समझा जाता है कि बेशेस डिजीज जो है वो सीधा आई वालों के पास आता है. आई प्रेजेंटेशन जो है, इनिशियल प्रेजेंटेशन इज ओनली इन 15 to 20%.
Yes, sir.
ज्यादातर जो प्रेजेंटेशन दैट इज ओरल अल्सरेशन. ठीक है. और ओरल अल्सरेशन जो है वो यूजुअली जो लोग इसको मिस करते हैं, बस जाके फिरते रहते हैं जीपी के पास, वो सोमोजेल एटसेट्रा वो दे देते हैं. और 70 to 75% पेशेंट जो है ओरल अल्सरेशन के साथ होते हैं. जब भी ओरल अल्सरेशन का केस हो उसमें जो इसका खास क्राइटेरिया आपने खुद दे दी है, तो उसमें लाजमी ये चीज जो है ना पेशेंट में लाइन, बिकॉज इट इज नॉट ओनली ब्लाइंडिंग डिजीज, रादर इट इज लाइफ थ्रेटनिंग एज वेल. और इसका जो शी इज लकी, शी इज हैविंग बेशेस सिंस लास्ट 13 years and she is still better. Thank you very much.
Thank you, sir.
Or the third presentation. Wonderful presentation by Dr. Hamza and Dr. Amna. And third presenter is me. My name is Dr. Fatima, and I'm currently working as a senior registrar of ophthalmology in eye department. मेरी है last one. अच्छा ठीक है, बैठे बैठे इसमें एडिट भी डाला है। हाँ, ये सेंटर। Okay, so my topic today is cataract surgery or phacoemulsification in any case of uveitis. And the aim and objective of this presentation is not only to discuss this very patient, but to discuss about any aspect of cataract surgery when you are dealing in case of uveitis patient. And we have to make sure the long-term success and explain the prognosis to the patient as well. So my patient was a 50 years old male and married, having 3 kids from Shah Jamal. He was shopkeeper by profession. Basically, he presented to us with a decrease in vision in the right eye, which was from the last 6 months, along with intermittent pain and redness in the right eye. On probing the history further, the patient has decrease in the right eye along with intermittent pain and redness, which was off and on, as I mentioned earlier. All these symptoms were progressive in nature. They were not associated with any diurnal variation, and there were no aggravating or relieving factors. The past ocular history of that patient told us that he was a diagnosed case of primary angle closure glaucoma. He was previously treated in some eye trust hospital, and he had an attack of acute congestive glaucoma in the right eye 13 months ago. He was treated there, and according to the record of the patient, he has surgical iridectomies and 1 YAG laser iridotomy in the right eye. The patient was giving a vague history of extensive laser treatment in the right eye, and according to that patient, that laser was the culprit. After that laser, the patient experienced pain, iritis, and secondary anterior uveitis. When the patient came to us in Fatima Memorial Hospital, he was on anti-glaucoma. He was on steroids and under cover of anti-glaucoma. And according to the patient, a prophylactic laser in the left eye was also done. I will only mention the significant ocular examination. The right eye vision was counting finger and it was not improving, while the left eye was fine. Vision was 6.6. Intraocular pressure was medically controlled. It was 18 millimeter of mercury in both eyes. So coming to the slit lamp examination of the patient, as we can all see that there is a peripheral iridotomy at nearly at 12 o'clock, which was patent on examination. Iridectomy at 3 o'clock nearly and 7 o'clock, and they were blocked due to the iris pigment. If you see closely, there are laser marks 360-degree on the peripheral iris, and there is overdone laser. These laser marks, as we can all see, they are brownish gray in color, and there are multiple rows of these lasers. And probably this is the laser eye treatment the patient was talking about, and it was overdone by some junior in eye hospital, I don't know about it. When coming to the lenticular changes, the patient has a complicated cataract along with posterior synecdoche from 2 to 4 o'clock and ectropia on uvei. Similarly, posterior synecdoche at 6 o'clock and ectropia on uvei superiorly. One thing which I like to mention is that the patient has no AC activity. When he presented to us, both eyes have medically controlled intraocular pressure. So that was not the problem. The patient basically came to us for decreased vision. He wanted cataract surgery. और the patient said कि डॉक्टर साहब मुझे नजर आना चाहिए सांस के अंदर. Okay, so coming to the pre-op treatment, first of all, we evaluated the patient and told him about the prognosis because this was not a simple case. Ultrasound B scan was done. Due to the poor view of the patient, we consulted the patient in detail about prognosis. Pre-op steroids. When we planned the surgery, we gave 1 week of oral delta-cortical prednisolone, 1 mg per kg body weight, and topical steroids were also done. In all this scenario, intraocular pressure was medically controlled. So this is the B scan of the patient. As we can see that there are no vitreous echoes, no posterior uveitis, and the retina is flat. So coming to the challenges in uveitis with small pupil and posterior synecdoche, not only for this case but for any case you encounter, there is reduced red glow or red reflex in such patients, and this can be a very tricky surgery for the surgeon. Coming to the damage or risk of the iris which the patient can face is increased risk of iris damage. When you are doing phaco in a very small pupil, there are many chances that you will damage the iris bleeding, iris prolapse from the wound, and small capsulotomy size, again due to the decreased view of the surgeon. And there are IOL complications, difficulty in the placement of IOL in the bag. Obviously, when the surgeon don't have a view, such complications can occur. Difficulty in the proper alignment of the IOL, and high risk of post-op inflammation. And high risk of post-op capsular phimosis, this will be faced 2 to 3 months after the surgery. So coming to the stepwise approach in managing seclusopapillae or any other similar case, intracameral mydriatics, they are very important. You should use them and you can use them generously. Viscodilation should be done at every stage. Posterior synecholysis 360 degree should be done, that you can result in a smooth surgery. Pupil stretching technique or multiple microsphincterotomies depending upon the choice of the surgeon, and pupil expansion devices. Intracameral mydriatics were prepared for this patient with epinephrine and 2% lignocaine and balanced salt solution. So coming to the intraop strategy in this case and other cases as well, we have to sweep, stretch and peel away. This is basically about the fibrotic membrane. You sweep to break the synecdoche with a cannula, and this is the key step. When you sweep 360 degree, then you stretch to dilate the pupil with 2 surgical instruments. And when this dilatation is done, you can easily peel the fibrotic membrane then. This is the peeling of the fibrotic membrane. We done it 360 degree. These are the pupil expansion devices. Normally all of us use iris hooks. These are the iris hooks and Melogen ring pupil expander and expand iris speculum. So the tips of the cataract surgery of phacoemulsification in uveitis with small pupil. First of all, use your cohesive OVDs such as Helon 5. The visco plays a very important role. Decrease your fluidic parameter, decrease the bottle height, decrease the vacuum, decrease the power. Use phaco chop technique. And in this phaco chop, put less pressure on the lens because the zonules are already weak due to the prolonged inflammation. Manipulate in the interior chamber. Your cataract should be here in the view. Don't go in the periphery, and use bimanual irrigation. So this is the pre-op picture. This is the surgery of the patient. We did the side port and viscodilation is done. Then we will go towards the main incision. You can see that this is visco in the AC. Now with the help of a diamond knife, we will give a 3-step main incision which is very self-sealing and good. This is very nice 3-step incision. So what do you expect is the next step? Ji?
Synecholysis.
Synecholysis is done. And with these 2 instruments, they are going to stretch the pupil now. Can anyone give the feedback that why the stretching is being done? Anyone? Okay. Yes. Yes. So this maneuver break the membrane, and you can see that now it is more easy to peel that membrane. In the video, we will show that membrane peeling is done only 1 quadrant, but in fact, we did it in the 360 degree all over so that the surgery is easy. At every step, viscodilation, visco is very important in this case. See, viscodilation is done. And you have a nice round pupil to proceed now. So now with the Utrata forceps, you are peeling the fibrotic membrane. You can see a small bleed on the iris due to that peeling. This maneuver was done 360-degree, and after that again visco was injected. So capsulotomy is being done with the Utrata forceps. The capsulotomy in such cases it is very easy because the capsule tend to run with the borders of the iris. It is done beautifully 360-degree. The red glow is very prominent. The cataract was complicated, but it was a soft cataract, and when the pupil was expanded, we can see a very good view. Now the hydrodissection is done, and you can see that the cataract is so soft that it is easily manipulated in the interior chamber, and now the surgery will be very smooth. The cataract is manipulated, it is freed. So in such technique, you are not putting any extra pressure on the zonules. So phacoemulsification is now processed. As the cataract was soft, this step was easy to do, and it was in the center, it was not in the periphery, and it was cleared. Later on, we did irrigation aspiration of the cortical matter, and lens placement was done smoothly, you can see. And in the end, intracameral steroids were also done. Sir, any comments? अभी इस वीडियो पे anyone like to comment on the video? अभी presentation बाकी है. Thank you, sir. Thank you. So in such case, intra-op and post-op steroids, they hold a very big place. It is said in such cases that by seniors that sink the patient in the sea of steroids. For our patient, we were giving him pre-op steroids 1 week before surgery, 1 mg per kg coated delta cotyl, and intracameral steroids, as I told you, they were also given. Periocular steroid in the form of PST, posterior subtenon Canacort, it was also given. So the post-op steroids, again, continuation of that oral steroid for 1 further week, and topical prednisolone, it was given. Again, the prognosis and the guidance of the patient is very important in such cases. After surgery, again, we guided the patient that there is higher risk of post-op inflammation, and you have to take care as compared to a normal patient undergoing cataract surgery. Cystoid macular edema and intraocular pressure rise, post-op IOP rise can occur. PCO is early and dense in such cases. So the take-home message of my presentation is that always counsel your patient and tell him about his condition, guide the patient, tell him about prognosis, sink the patient in the sea of steroid, and intensive post-op follow-up at day 1 after surgery, day 3, day 7, and then if the patient is okay and fine, you can ask him to come after 2 weeks. Thank you so much. जी सर.
Sink the patient in sea of steroid.
सर पेशेंट डूबेगा तो उसका फायदा हो जाएगा. डूबेगा तो बचेगा.
के केसेस में
जी सर.
यूजुअल टीचिंग क्या है कि कब सर्जरी करनी चाहिए?
सर जब हम लोग की जो एक्टिव यूवेइटिस है हमने उसको डील कर लिया और पेशेंट का प्रेशर भी कंट्रोल है मेडिकली साथ.
कितनी देर वो कंट्रोल होनी चाहिए जो है ना हाई को है?
सर 3 to 4 weeks before surgery.
अगर कोई उससे पहले करना पड़ जाए तो
Sir, I guess with extensive steroid cover orally and topically, you can do the surgery, and you have to weigh the balance of giving anti-glaucoma and steroids as well.
I would like to share my experience in one case especially.
Ji sir.
Thank you very much. It was a nice presentation.
Thank you.
It was really good.
Thank you.
Your teaching is that in case of uveitis, anti-uveitis, I should be quiet at least for 3 months. Some people say that 2 months is sufficient.
Okay.
Anyhow, you have to see each case on its merits. Around 2 years back, I came across a patient, around a 45 years old lady, having bilateral, जो उसको diagnose किया हुआ था, गया था bilateral acute congestive glaucoma in the periphery and was being treated like that. When I saw her, she was having acute anterior uveitis.
Okay.
And at the same time, उसके एंटीरियर चैम्बर शैलो थे जिसकी वजह से वो किसी ने उसको मिसडायग्नोज किया कि उसको प्रेशर भी ज्यादा था. तो उस वक्त तक उसके पोस्टर्स आने की बन चुके थे, लेकिन पीपल के कुछ डायलेट करने से कुछ फर्क पड़ता था. एनीहाउ आई ट्रीटेड हर, लेकिन आईओपी उसका कम नहीं हो रहा था. कैटरेक्ट जो दोनों आंखों में उसको साथ इंटुमिसेंस कैटरेक्ट था, यानी बहुत ज्यादा कैटरेक्ट, लेकिन लेंस जो इंटुमिसेंस था, शी वाज ऑलरेडी हाइपरमेट्रोप और उसका इंट्यूशन शैलो था. तो प्रेशर उसका 240 की रेंज में विद फुल मेडिकेशन. एक कंसिडरेशन ये थी कि इसमें जो है ना वो ये की जाए, लेकिन उसमें टाइम लगना था उसके ठीक होने में, कि इन्फ्लेमेशन है फिर फ्लेयर होना था, और डेफिनेटली उस पेशेंट ने क्रॉनिक एंग्लियोपेनिया ग्लाइकोमा में चले जाना था. सो आई थॉट अबाउट इट, उसको कि कैसे सिंक करें स्टीरॉयड में.
ठीक है.
रूटीन में मेरी जो यूवेटिस के पेशेंट में मेरी रूटीन है कि इनको 1 week बिफोर सर्जरी स्टार्ट सिस्टेमिक स्टीरॉइड्स plus topical. Of course, you are using topical as well.
Yes, sir.
And my routine is I inject betamethasone subcutaneously 1 night before surgery.
Okay.
But in that case, I gave the patient methylprednisolone 1 day before surgery, intravenous 1 gram.
Okay.
Apart from systemic steroid and topical steroids. And did one eye. Of course, I had to face a lot of uveitis, but that was controlled. And in the same course of steroids, after 1 week, I again gave her intravenous 1 gram methylprednisolone.
Along with the oral.
And did the other. Now she is fine. She is having 6-9 in both eyes. But at times you have to decide other way as well.
Intensify the regime.
Thank you.
Thank you, Dr. Fatima and Dr.
Ji, sir.
What were the laser marks on the iris?
Sir, we discussed it that this is basically some iridoplasty done. Iridoplasty being done to pull the iris and to open the angle, because it is somewhat a controversial type of laser. That is why I haven't mentioned it earlier. But in my opinion, this is laser iridoplasty.
Thank you very much. It was a wonderful presentation and wonderful discussion on the subject. This was very tricky. I am a high volume cataract surgeon and I do so many of uveitis cases as well. I follow the principle, but this was definitely tricky. Dr. Javed, I used to sing, but Dr. Javed drowned the patient in the sea of steroids, in addition to oral intravenous sodium succinate, without sodium succinate. Very good. And thank you very much for the comments.
Thank you,
this
sir.
This patient was maltreated. Its uveitis was not primary uveitis. It was secondary to over-treatment of iris with iridoplasty. मैं यूके में था तो एक बंदे ने iridoplasty शुरू की थी मूर फील्ड में. वो प्रेजेंटेशन दी उसने सिमिलर कि I am doing this iridoplasty and I am treating the iris, pulling it away from the angle and converting it to open angle. तो क्या था उसके बारे में एक उधर के दोस्त था, हमारा सीनियर कंसल्टेंट था, मैं तो ट्रेनी था. वो कहता है कि they were very rude. There was very heated discussion. वो कहता है, my dear, you did a good job for your ideas, but in my opinion, it is not iridoplasty, it is idioplasty. Idiot is blasting the iris. There was quite a well side of things लड़ाई शुरू हो गई थी वहाँ पे. So there are a lot of controversies on the subject, but it's not a good idea to do that. That will lead this patient to this problem. Thank you very much.
Thank you. Now I will like to call. Okay, sir.
एक छोटा सा,
जी सर.
फातिमा ने तो डुबकी लगाई बंदे को स्टीरॉयड में.
जी सर.
चौधरी साहब कहते हैं कि उसे सबमरीन में बिठा के नीचे भेजो.
ठीक है सर. ठीक. सर जितनी जरूरत होगी उतना डुबो देना पेशेंट को. ठीक है सर.
But I must say it is not easy. It is very difficult.
Yes sir.
Surgeon gets sleepless nights when
Yes,
this happens.
Yes
You
sir.
think, and steroids जब आप सोचते हैं कितने देते हैं, 1 milligram per kilogram body weight देते हैं.
जी सर.
Yeah.
1 mg per kg body.
Yeah, minimum
Minimum.
that should be the dose.
Yes.
And sometimes you might have to make it 1.5 milligram per kilogram body weight and ask your physician colleague to keep
Yes
a
sir. The
watch
patient can be diabetic.
on blood pressure, heart decompensation, and so many other things which are associated with the high dose of steroid.
Yes.
But you are really forced otherwise. One have to be very energetic to do it, and you are. Good.
Thank you so much sir. Assalamu alaikum sir. Now I will like to call Assistant Professor Dr. Abdullah Mazhar, and his topic is platelet-rich plasma in the treatment of retinal degenerative disorders. Thank you.
This is an innovative technique, and this is an technology as well. Partly was considered to be a disease incurable, but now we are progressing with the treatment.
Okay, Assalamu alaikum everyone. My topic of case presentation is basically something very new in our country or our region, because it has been, people have been doing this a lot in foreign countries, but we were not doing this. So something new and something very informative. It was for me as well, and I hope so it will be for you as well. So it's basically a series of 3 cases which were who have RP, retinitis pigmentosa, and they are being treated with the autologous platelet-rich plasma. So they will be having their feedback as well. So my first case is 20 years old male. He was a student, resident of Lahore, and he presented with decrease of vision since childhood, more at night than day. Visual acuity in his both eyes were with glasses counting finger, and which was not being improved with pinhole or any infection. In anterior segment examination, he was bilateral pseudophakic with history of left yak capsulotomy, and on posterior segment examination, he had retinitis pigmentosa with maculopathy. This is his OCT, which shows clearly atrophic changes with outer retinal layer atrophy, disruption in both eyes. Visual field examination 30-2 degree, in which there is obvious loss of peripheral vision field in both eyes, especially in the left eye, and the right eye had a bit central field intact. This is microperimetry central 10 degree visual field examination. Again, on this field, you can see there is significant loss of field, central field also in his both eyes, more in left. This is his ERG. ERG shows decreased magnitude of the waves, increased implicit time in both scotopic and photopic stimulus, and there was this corresponded with the findings of RP. So he was treated with autologous platelet-rich plasma. 5 sessions were done, and there was improvement in his vision in right eye, 3 lines improvement in his left eye, 1 line improvement on Snellen's chart. He also said that he had some improvement in his peripheral visual field. So this is basically his feedback, which is played with their consent.
मेरा बेटा भी एमओ है, इसको 12 साल से नाइट ब्लाइंडनेस है, तो उसके लिए डॉक्टर साहब इंजेक्शन लगा रहे हैं प्लाज्मा का। तो अभी 6 माह इंजेक्शन को लग रहा है, काफी बेहतर है। अब तो मार्केट भी आता है, अपना शॉपिंग करता है, पहले बिल्कुल ही डर हो गया होता। अल्लाह का शुक्र है, काफी बेहतर है।
ठीक है जी। आपको लगता है कि इंजेक्शन लेने के बाद अहमद की नजर में कुछ बेहतरी आ रही है?
बहुत बेहतरी है। मेरे घर पे चार्ज लगा हुआ है, उस पर एक लाइन भी नहीं पड़ जाती थी, अब ये 4 लाइनें पढ़ देते हैं।
बिल्कुल माशाल्लाह। अहमद, आपको लगता है कि इंजेक्शन के बाद आपकी नजर बेहतर हो रही है? शुक्रिया। आपकी इजाजत से ये वीडियो हम दिखाना चाहेंगे दूसरे डॉक्टर साहिबान को, आप अगर इजाजत देते हैं हमें तो।
हाँ, दिखा दीजिए।
So the father said that he has talent chart in his home and he checks it himself and he has improvement in vision. The other case, she is a PhD doctor, 32 years old female, resident of Lahore. Again, same symptom, decrease of vision more at night, decreased peripheral field, difficulty in color appreciation, visual acuity was with glasses 612 in both eyes, no improvement on pinhole or BCVA. Intersegment, on intersegment examination, she has early posterior subcapsular cataract and again RP with maculopathy on posterior segment examination. It's her OCT scan, which again shows atrophic changes with outer layer atrophic changes, inner segment, outer segment disruption with RPE changes a bit. OCT scan showing severe thinning, atrophic changes on the macular area. This is a visual field which again shows severe visual field defects on both eyes. She was treated with 3 sessions of PRP and she reported improvement in her peripheral vision along with generalized light perception improvement. So we couldn't get her consent for video, so we had her audio message for. Sorry.
I'm holding a PhD degree in physics और मुझे RP disease है. मुझे एग्जैक्टली याद नहीं है कि इसके सिम्टम्स मुझे कब क्लियरली आने लगे थे, लेकिन आई गेस 2016 में मुझे इसका मतलब काफ़ी सीवियर किस्म के सिम्टम्स महसूस हुए, लाइक नाइट विजन का प्रॉब्लम मुझे होने लग गया. इसके अलावा आँखों के कॉर्नर से मैं देख नहीं सकती थी क्लियरली, और विद द पैसेज ऑफ टाइम ये सारे जो सिम्टम्स हैं सीवियर होते गए. इसके अलावा जो डार्क कलर्स हैं उनके अंदर पहचान नहीं रहती थी, सीनियर चढ़ने उतरने में प्रॉब्लम, और इवन अब करीब आ गए काफ़ी कुछ अर्सा पहले डे टाइम में भी मुझे काफ़ी प्रॉब्लम रहती थी संभाव. तो मैंने डॉक्टर अब्दुल्ला को कंसल्ट किया जुलाई 2022 में, और उन्होंने बताया कि मुझे आफ्टर एग्जामिनेशन उन्होंने बताया कि मुझे RP है. उसके बाद जनवरी में उन्होंने सजेस्ट किया कि PRP इसका ट्रीटमेंट है. तो पहले डेज अगो भी मेरा इसका 3rd सेशन हुआ है. तो मतलब आफ्टर वेरी फर्स्ट सेशन मुझे थोड़ा बेटरमेंट महसूस हुआ. जैसे मैंने पहले बताया कि कॉर्नर से बिल्कुल भी मुझे ऐसा लगता था मैं नहीं देख पा रही बिल्कुल भी, लेकिन अब मुझे ऐसा महसूस हो रहा है जैसे कोई लाइट, जैसे थोड़ी सी लाइट जो है वो एंटर हो रही है आँखों के कॉर्नर्स में से. सो मुझे थोड़ी सी बेटरमेंट जो है वो महसूस हुई है.
सो पेशेंट रिपोर्टेड दैट मुझे कॉर्नर से नजर नहीं आता था, और अब उन्होंने कहा है कि मुझे कॉर्नर से बेहतर महसूस हो रहा है, मुझे लाइट परसेप्शन कॉर्नर से बेहतर. सो कॉर्नर से मुराद उनकी पेरिफेरल फील्ड है जिसमें उनको बेहतरी महसूस हुई आफ्टर इंजेक्शन. So third case is 33-year-old male, resident of Miawali. Again, same symptoms: decrease of vision more at night, visual acuity 3/16 right eye and 6/36 in left eye. No improvement on refraction or pinhole. Intersegment examination was unremarkable. On posterior segment examination, again RP with maculopathy. He was treated with 2 sessions of autologous PRP, and he reported improvement in vision and generalized light perception. Again, we have his feedback.
जी, मेरा नाम औरंगजेब है, मैं डिस्ट्रिक्ट मियाँवाली तहसील सखेल से हूँ. मेरा डॉक्टर साहब के पास आज 3रा इंजेक्शन के लिए आया हूँ. मुझे RP की बीमारी है, मुझे काफ़ी मसला है. पहले 2 इंजेक्शन लगाने के बाद मुझे मेरे आंखों पर जो अंधेरा आता था उसमें कुछ कमी आई है. आज मैं 3रा इंजेक्शन लगवा रहा हूँ. मुझे उम्मीद है कि अल्लाह ताला इंशाल्लाह मुझे इससे काफ़ी बेहतरी में नजर में कर देगा. और मेरी एज 33 है और इंशाल्लाह मुझे उम्मीद है कि मुझे इससे बेहतरी होगी.
और आपके एक और भाई को भी उसका ही बता दें.
जी, मेरा एक और भाई है, उसका नाम शबीर है, उसको भी ये मसला है RP की. हम दोनों भाइयों को जो पैदाइश की मसला है, पहली स्टेज पर एक काफी कम था, जो उम्र बढ़ती है कि बीमारी काफी ज्यादा होती जा रही होती जाती है और नजर चली जाती है, इस तरह हो जाती है.
So again, he reported some improvement in his vision. His brother also reported improvement in vision, and this period is being played with his consent. Okay, so what is RP? We all know what is RP. It is basically a progressive autoretinal degeneration, mainly rod cone dystrophy. There are almost 60 genetic mutations which have been reported in the photoreceptors as well as for retinal pigment epithelium. The main reason why RP occurs is basically apoptosis and photoreceptors loss, which is basically the reason in all genetic types of RP, whatever the inheritance patterns is. Symptoms night blindness, which begins in childhood, and then it is progressive vision loss in day as well. Then it leads to loss in day as well. The main visual fields will start in the mid periphery and then it goes toward the center, and eventually it leads to legal blindness. Central visual acuity in RP is usually preserved until the late stages because there is some paracrine effects of Muller cells which make some synaptogenesis, ectopic synaptogenesis in the central 19-degree. And there's Muller cell hypertrophy. That's why the central vision is spared until the late stages of RP. So, and the BCI also remains usually stable. In the signs, the pathognomic sign is bony spicules. In the fundus examination, attenuation of blood vessels, mainly of the arterioles. There's pale vaccidisc and optidisc, and there's some complication. If there's a little bit inflammation in the eye along with the arpit, then these complications can occur, which is cataract, epiretinal membrane, and macular edema. So main thing, why RP happens? The main there are so many proposed hypotheses or even the proven facts in animal models, even some human researches, that the main factor is growth factor withdrawal at the cellular level. Whenever there is growth factor withdrawal due to any reason, mainly in RP due to the genetic mutations, there is apoptosis of the RPE and the photoreceptor cells. So before the apoptosis, along with the apoptosis, they go with the progressive atrophy, and during the apoptosis stage, before that, the cells goes into the dormant cell phase, which is right before the apoptotic death. So apoptosis causes reduction in the thickness of the outer nuclear layer as well as retinal pigment epithelium. And this genetic mutation, this also leads to defects in the synthesis of rhodopsin, which is the visual pigment of the rod, and in the growth factors, deficiency in the growth factors, these all lead to the same result, that is apoptosis of the photoreceptors as well as for the RPE. So the time where this process is going on and there is still no apoptosis, the cells, the RPEs, the photoreceptors, they get into a dormant state, that is the standby stage or the sleep mode state. That is the point where if we can treat them somehow, we can just revert them to the normal stage. So some photoreceptor cells die and some get into the suspended animation, the dormant stage. The length of this period, like we all know that according to the genetic type, some RP presents early, some late. This is the reason, the dormant stage. In some genetic types, this is a prolonged stage, and in some it is very early. The other proposed mechanism is sequestration of glucose in RP, which cannot be delivered to the photoreceptors, and eventually there is a death of photoreceptor cells. Starvation leads to impaired synthesis of growth factors, metabolites, all the necessary things required for the sustainability of cells. So again, another mechanism, there is a lack of rhodopsin synthesis in the RPE, which leads to the calcium channel opening, and that can induce also apoptosis. So these all things lead to a loss of inability to take in sufficient nutrients by the cells, and to maintain the cell integrity, we need growth factors. All these mechanisms, they lead to decrease in the growth factors, which lead to the apoptosis and death. So what is autologous platelet-rich plasma? It's a biological product which is having higher concentration of platelets. So what we have in platelets, we have more than 30 growth factors and cytokines, including all this, and there are more than 800 different proteins which are secreted in the surrounding after we inject the autologous platelet-rich plasma. So how does PRP act?
There are multiple mechanisms: cell proliferation, angiogenesis, cell migration, which is stimulated, then neurotrophic, these are neurotrophic, anti-apoptotic, hemorrhagic, and immunomodulatory action of growth factors, cytokines, which growth factors and cytokines, which can be used directly or in the cell-mediated way. So these again, these can regulate the energy cycle, local capillary, control the local capillary blood flow, immunogenesis. So the main thing is that they increase the nutrition of the cells, nutrition of the dying cells, anti-inflammatory effects. All these growth factors lead to endothelial regeneration, reperfusion, tissue repair, angiogenesis, again development, and again they are involved in the development of a new capillary plexus because they also have vascular endothelial growth factors. Cytokines, all of cytokines, they have restoring effect on restoring function, and this function is due to the trophic capacity of platelet-rich growth factors. So what we are doing, that we are increasing the level of neurotrophic growth factors after injecting autologous platelet-rich plasma, septenon, at the septenon level, and which leads to increased nutrition in the microenvironment of the photoreceptor cells, and thus activating the photoreceptors that are in sleep mode, the dormant mode. So how to inject, how we prepare it, how we inject it. Half-life of PRP usually 4 to 6 months. A single dose of PRP usually 4 to 6 months. The growth factor in that through activation or reactive. So we do not inject directly the PRP, we have to reactivate it. So the methods of reactivating either through sodium chloride or sodium citrate or calcium gluconate. We activate them with this chemicals, and then we inject the platelet-rich plasma. There are initially 3 loading doses, which are 2 weeks interval: first day, 15th day, and 30th day. And there are booster doses, which are 4 to 6 months apart. After 4 to 6 months of the third dose, and then it is documented in the research in the that the PRP can decrease the photoreceptor loss by approximately 3-fold. So how does the growth? How do the growth factors reach to the target area? Through the scleral pores, go through the tyrosine kinase receptors, which are present around limbus, extraocular muscles, and the optic nerve. So they attach to these pores, these receptors, and they go to the target area. And the molecules which are smaller than 17 kilodalton, they can pass easily through the sclera via simple passive transport, and they don't need any receptors for that. So these are other sources of platelet-rich plasma other than patient's own blood. These are fetal bovine serum, allogenic from others person, umbilical cord serum. But what are the restrictions constraints? That these platelet-rich plasma can cause higher risk allergy reactions, or these can transmit the infectious diseases. So how are we going to assess the result if we are injecting a person with a PRP, and how we are going to assess the result? There are multiple modalities. First of all is the visual acuity. Usually visual acuity is not a good modality for assessment because the central vision remains the same. We already talk about that why. So it's not a good modality, but some patients usually report good improvement in visual acuity after the PRP injection. And the reason is again same that I already described, that there is ectopic synaptogenesis. Central vision remains same, or it sometimes get improved, like one of my patients. Vision field is one of the good prognostic factors for the assessment of the treatment. It is related to the number of photoreceptors. The more the photoreceptors, the better with the visual field. So if we can match the pre-injection visual field with the successive visual fields, we can just see the change. If there is any good results, we can see it, compare the both visual fields, and we can see the change. Usually, then there is a severe field loss. 30-2 visual field is not that much authentic. Then in that case, we have to do the microperimeter, that is central 10-degree visual field. That is more accurate for the good results. Fundus autofluorescence. So we can have a fundus autofluorescence picture on which you can see the hyperautofluorescent rings around the macular area, which actually shows the RPE loss and pigmentary changes. If you see that in subsequent fundus pictures, that autofluorescence pictures, that these losses are stable or probably getting improved, that this means that our treatment is getting us some good results. OCT is a very good modality because it sees the inner segment, outer segment of photoreceptors, and that is basically ellipsoid zone on spectral domain OCT. which shows the segments of the photoreceptor cells. So more the loss of ellipsoid zone, worse with the vision and the outcome. But we can compare or even calculate the ellipsoid zone thickness on the OCT. Just like we see the macular hole thickness, we can also see the compare and document it with the help of an OCT, and we can compare it with the subsequent OCTs that whether it is getting better or not, it is improving or not. ERG, multifocal ERGs and full field ERG. There are two modalities of ERGs. When there is extensive loss, full field ERG does not give you exact results, the precise results. When there is extensive loss of retina, there is a advanced stage RP, then we have to rely on the multifocal ERG, because multifocal ERGs gets us result on different planes, different points of retina. But in the full field ERG, we usually get a generalized result, which is not very authentic in RP patient if it is RP is advanced. Okay, the same thing that just I told you. The best thing, documented in literature, my personal experience, ask the patient, how do you feel? In fact, in my practice, I always ask the patient before the next injection, how do you feel? If you are satisfied with my treatment, with this treatment, if you think you are getting improvement, let's go for another injection. When he says, no, I am not feeling any improvement, I don't want to continue it, I just stop it. And this is what is the main treatment assessing criteria even in the other countries, the outer foreign countries, where it has been done very commonly. In my personal experience during my fellowship in Turkey, I had a chance to see the data of 400 patients of RP which were being treated with autologous PRP. And the consultant there, she told me that we don't get much changes, better changes in visual field or OCT, to be very honest. But whenever I inject my patient with an PRP injection, I always ask, do you feel better? Have you felt better with my previous injection? And if he says, yes, I am feeling better, then, in my personal experience, my patient called me himself, sir, मैंने इंजेक्शन लगवाना है, मेरा टाइम हो गया है. So अगर एक पेशेंट है वो उसको अच्छा लग रहा है इंजेक्शन के बाद, he or she will call you herself or himself for the next injection. There were some proposed side effects, complication of these injections which were in literature, but none of them happened. Ocular side effects, systemic side effects, all the ocular side effects, hemorrhages, alteration, interface alteration, tears detachment, all these, none of them happened in 4 years follow-up of the patients in literature, and no systemic allergic reaction or any reaction as well. So no documented complication. Only one side effect you can say, pain, a severe pain for 2 to 3 minutes after injection. That's it, nothing else. So subtenon injection of PRP, it's a good therapeutic option for an RP patient or for some macular degeneration as well, or optic neuropathies, because the mechanism is same. And long-term results and adverse effects, we actually don't know, because in literature we have only 4 to 5 years data, that's it. We don't have longer data. But in my personal experience, I have been doing this for 8 months now, and up till now, only one patient, my one patient, he is not coming back because he said, yes, मुझे नजर तो आता है, उसके बाद बेहतर होता है, but जैसे ही असर खत्म होता है वो वापस चला जाता है. तो मैं बार बार लगाता हूँ, मुझे बार बार आना पड़ता है. So मेरे एक पेशेंट जो है उसने क्विट किया. Otherwise, I have so many patients of RP and I have been injecting them with PRP, autologous PRP, and they are very satisfied. Thank you. Any questions, please? गुड क्वेश्चन. अच्छा, इसमें भी जो है ना, ये भी बिग डॉक्यूमेंटेशन अभी रिसर्च इस पे चल रही है. मैंने बताया कि 4 साल जो है ना वो मरीजों को मैंने देखा डाटा 4 साल से आ रहे हैं. यस, दिस कैन बी वन ऑफ थिंग्स कि हाँ उनको लाइफ लॉन्ग इंजेक्शन लगते हैं, क्योंकि हमने देखा कि ग्रोथ फैक्टर्स का जो है ना वो हाफ लाइफ 4 to 6 months है, और जब वो उनका जो है वो एक क्वांटिटी कम हो जाती है in the environment, micro environment, तो yes, they need more growth factors, क्योंकि basically the fact is कि genes में जो growth factor बना रही हैं, उनके इंटरनल में growth factor नहीं बन रहे, so they have to have from other source. अभी तक इस पे भी रिसर्च है कि हाफ लाइक ये जो 4 to 6 मंथ्स है लिटरेचर में लिखे है, बट जिससे कि हमें अभी भी नहीं पता. बट थिंग इज कि यस, मैं 3 से 4 महीने बाद रिपीट कर देता हूँ, क्योंकि प्रैक्टिकल कुछ चीजें हमारी क्लिनिकल एक्सपीरियंस होती हैं. जो मैंने सीखा देखा उसमें ये है कि 3 मंथ्स इज अ सेफ पीरियड जिसमें आप रिपीट कर सकते हैं.
So nice presentation.
Thank you, sir.
I would like to ask कि कोई are there any inclusion criteria in cases of retinitis pigmentosa which you would include, or every patient is likely candidate for that? I mean criteria in terms of number one vision and number two an OCT or some other diagnostic. I mean scientific criteria.
Yes, sir. Definitely there are criteria. The patient having poor vision, like PL, quadrants negative, hand movements. I usually counsel them not to go for this, because even if they are gonna get this injection, they are not gonna get much improvement. It depends how much there is damage on the retina, on the OCT, clinically on the visual field. Like just like I have injected a patient 2 days back. She had PL vision left eye and 616 right eye. So I get in only one eye. I just told them not to get it in the left eye because it has PL vision. You are not going to get much benefit from this. So yes, this is the criteria. On the OCT, definitely extensive damage, extensive atrophy, visual field all black, and vision is very poor. Yes, you can just counsel them not to go for it.
So, you mean better earlier treatment and better?
Yes, this is the most important point. Earlier the treatment, good with the results, because we will having the more viable photoreceptors and RP cells.
And any difference between patients who have got maculopathy or not maculopathy, only just peripheral? I mean, there is no difference in patient with maculopathy.
No such difference.
Second thing, have you tried this in the cases of like other diseases like atopic?
I have been
atrophy, macular atrophy.
Sir, I have been doing this for the Stargardt disease.
But not in AMD. Have you tried in AMD?
No, not in AMD right now, because I'm myself, to be very honest, I am doing it for research purpose. So I am sticking to the degenerations right now.
Degeneration.
Like congenital hereditary dystrophies.
How much is the quantity which is there?
So it depends on the disease, how much the disease has progressed. It usually varies from 1.5 to 2.5 ml per eye.
ये इनका क्वेश्चन था, इट इज नॉट गुड फॉर डिजेनरेटिव डिसऑर्डर्स ऑफ नॉन एटियोलॉजी. AMD of non etiology and treated it accordingly. It is for dystrophy where growth factors are deficient.
Actually, I was talking about when there is geographic atrophy in AMD, dry AMD cases. Not from the wet form.
So actually they have been doing this for even the AMD also. क्योंकि लॉस तो सर आरपी का अभी हो रहा है ना, उसके अंदर भी यही फैक्टर है, बट अगेन इस पे बहुत ज्यादा नहीं है, हेरिडिटरी के ऊपर ज्यादा फोकस है, बट ग्लूकोमा के लिए भी हो रहा है सर. ये ग्लूकोमा ऑप्टिक एट्रोफी के लिए भी हो रहा है, ग्लूकोमेटिस ऑप्टिक एट्रोफी के लिए भी.
Dr. Abdullah,
सर,
very exciting topic.
थैंक यू सो मच सर.
Very much disturbing for the patients who are gradually going blind, and a ray of hope. But with a caution. These people, they have been treated in the past as well. I can recall what happened in the last 40 years. We had these injections, we had this Aluplant from Russia, and various results were claimed. Well, what was material is a different thing altogether, what you are trying to do. Question is, really, how many cases have you done?
So I have,
and what are your results?
So
because there are loads of people.
Yes.
The whole stadium is full of people waiting for you to help them out.
So
all varieties of retinitis pigmentosa.
Yes.
You are talking of probably one type, or does it include a basket of retinitis pigmentosa cases?
Okay. Sir, I came back from Turkey in January after my fellowship there. I rented from there. So in last 8 months, I have treated 15 patients, 30 eyes, 29 eyes. One I didn't do, the last patient I didn't do that. And only one of my patient, he quit it. And he quit because he said that मुझे बेहतरी होती है, but मैं बार-बार नहीं लगवा सकता. One thing is. Secondly, I am doing research on it, तो अभी I have to publish it the long term results. कि अभी मेरे पास 8 महीने का डाटा है, वो भी जाहिर बात है ऊपर नीचे पेशेंट्स इकट्ठे तो आए नहीं. अभी तक के उसके अंदर आए मुझे पॉजिटिव, सब्जेक्टिवली पॉजिटिव मिले रिजल्ट्स, और कुछ मेरे टेस्ट के ऊपर भी, और कोई कॉम्प्लिकेशन मैंने नहीं देखी अभी तक सिस्टेमिकली या ओकुलरली, और इट्स अ सेफ मेथड बिकॉज ऑटोलोगस सीरम है। और जो मैंने देखा और सीखा उसके अंदर तो सर 4 साल का डाटा है ऑटोलोगस सीरम के साथ, जिसमें कोई कम्युनिकेशन नहीं है, इंप्रूवमेंट ही है। सो जैसा मैंने दूसरे सीरम्स के सोर्सेज की बात की, यस अगर हम उनको यूज करते हैं दे कैन बी सो मेनी कॉम्प्लिकेशंस, बट विद ऑटोलोगस हमें लगता है और अभी तक रिपोर्टेड भी नहीं है कि कोई कॉम्प्लिकेशन हो सकती है। सो एक और चीज सर की जेनेटिक मैपिंग पे बहुत डिपेंड करता है। अब हमें यहाँ पे नहीं पता कि इसको रिसेसिव है कि डोमिनेंट है कि एक्स लिंक्ड है कि स्पोरेडिक है, हमने कभी करवाया ही नहीं काम। लेकिन ये वर्बल बात है कि मैंने जब बात कंसल्टेंट से पूछा कि आप, क्योंकि वो लोग करवाते हैं जेनेटिक जो है ना इसके मेकअप पे क्या है, तो वो उन्होंने बताया कि हमने सब में सेम रिजल्ट देखा, हम पर्टिकुलरली किसी एक जेनेटिक इनहेरिटेंस के साथ रिलेट नहीं कर रहे। उनके रिजल्ट से सर ये उन्होंने दिखाया कि ऑटोसोमल डोमिनेंट में अच्छा है, रिसेसिव में कम है, लिंक एक्स लिंक में अच्छा है, इसमें स्पोरेडिक में कम है, ऐसा कुछ नहीं है। ये रैंडम रिजल्ट्स हैं सर, किसी में भी अच्छा आ सकता है, किसी में कम रिस्पॉन्स आता है, किसी में अच्छा रिस्पॉन्स आता है। ओनली वन थिंग रिस्पॉन्स को जो आपको कर सकती है वो है एक्सटेंट ऑफ लॉस। जैसा सर ने अभी कहा, सर से बात हुई कि कितना लॉस है आपकी विजुअल फील्ड के ऊपर, आपके ओसीटी के ऊपर, आपके ईआरजी के ऊपर, आपकी विजुअल एक्यूटी के ऊपर, आपके फंडस एग्जामिनेशन के ऊपर। मोर द लॉस, लेस विल बी द फेवरेबल रिजल्ट्स। सर इसमें बेसिकली हमने ब्लड लेना है पेशेंट का, वी हैव टू स्पिन इट, वी हैव टू रीएक्टिवेट इट, reactivate through certain concentration of certain chemicals which I mentioned, or then we have to keep it for some time at some particular temperature. इसमें डिफरेंट थ्योरीज हैं, डिफरेंट लोग डिफरेंट तरह से कर रहे हैं, डिफरेंट क्वांटिटी के साथ रिएक्टिवेट कर रहे हैं, डिफरेंट टेम्परेचर के साथ रिएक्टिवेट कर रहे हैं। तो अभी ये है कि मैं दोनों को यूज कर रहा हूँ, आई एम कंपेयरिंग द डाटा। होपफुली इंशाल्लाह विद इन 6 months or 1 year आई एम गोना पब्लिश अ पेपर ऑन दिस, डिटेल पेपर जिसमें ईच एंड एवरीथिंग। So this is on research purposes, not yes. सर मैं हैरान था जब उन्होंने मुझे कहा कि मारपे की ट्रीटमेंट करता है, उससे अच्छा हम तो लोग विजन 8 के बाद मरीज को तसल्ली दे देते हैं बस। सर ये आपको अलग से बताऊंगा सर। सर यहाँ पे आपको पता है कि यहाँ पे नहीं लग रहे, हम सिर्फ 2 लोग कर रहे हैं, तो आपको दूसरा अलग सस्ता मिल जाएगा उससे। ठीक हो गया सर। सर देयर इज नो एज लिमिट, आप किसी भी एज पे स्टार्ट कर सकते हैं। आपके पेशेंट आपके पास आरपी का प्रेजेंट कर गया अगर तो, और आप विलिंग है वो, आप उसको सारे प्रोज एंड कॉन्स बता दें, आप कर सकते हैं। इसमें एक चीज इम्पोर्टेंट ये है कि हम कभी पेशेंट को एग्जैक्ट रिजल्ट का नहीं कह, वो हमसे पूछता है कितने लाइन इंप्रूव होगी, कितनी वेल इंप्रूव होगी, हम कभी ये नहीं बताते हैं उनको। हम कहते हैं हम रेशो लगाते हैं, अच्छे रिजल्ट्स हैं, लिटरेचर में हैं, लेट्स सी क्या होता है। थैंक यू।
Thank you, wonderful presentation. Now I would like to call Professor Haroon, head of the rheumatology department, and the topic he will be discussing is non-infective uveitis from the perspective of a rheumatologist. Welcome, sir. Sir, आपका ऑनलाइन भी जाएगा।
नहीं एक और होगी, हाँ एक 2 थी, सेकंड, हाँ ये वाले, हाँ। जहाँ मर्जी कर लें।
ओके सर की ऑनलाइन भी जाएगी ना साथ?
खुल जाएगी वरना वो चले जी। अस्सलाम वालेकुम एवरीवन। तो the topic for today, as you would have seen, is non-infectious uveitis. So I've got about 15-20 minutes, I suppose. So there's loads of slides, loads of slides. So I'm just going to run off very quickly. Important thing, of course, is very rightly so. Like it wasn't a very specific, it wasn't a very bad back pain as such, but he did mention that he does have now and then back pains. It wasn't very classic of inflammatory pains. He never noticed or he never sort of mentioned this or requiring any GP or rheumatologist or orthopedic opinion. So again, the uveitis was very mild as well, was just the topical steroids was doing the trick. Investigations, of course, the HLA-B27 turned out to be positive. And now the question is like, should you be referring from the ophthalmologist and this particular patient to a rheumatologist or not? As I said, very sort of the mild mechanical back pain. The uveitis is mild as well, just gets relieved with the topical treatment only. But if you look at the DUET algorithm, which we'll be discussing a little bit, this is the one that we were involved in. And depending on this particular algorithm, just purely as you can say, the recurrent acute anterior uveitis with the mechanical back pain with the HLB27 positivity, there is a more than 97% sensitivity and specificity that this patient has got undiagnosed ankylosing spondylitis. Third question is like how these arthropathies differ as regards their ocular manifestation as regards uveitis, for example. So this is an old lady, like middle-aged lady rather. So she presents with a very florid onset of uveitis, very florid onset. As you can see, within 24 hours, she was having the vision loss. She also had few days history of dysuria, the typical of the UTI. So the usual scenario, of course, the reactive that you can think of, that also, but was very aggressive. There was a vision loss. As you can see, the left side was the hand movements only. So just the reason why I'm just putting this out is that sometimes the reactive arthritis threatening disease. So this patient did very well, of course, with the usual. We ended up pulsing him because she was losing her eyesight. Fourth one, in terms of talking about some steroid sparing agent, or when should you be considering about the second line agent. So 18 years old girl continued to have repeated episodes of acute anterior uveitis. She did have a strong family history of arthritis by herself. She did not have any symptoms whatsoever as regards arthritis. So it was purely family history, HLA-B27 positivity, having repeated attacks of the uveitis. So what should you do? But continue, even though she was using the standard sort of the topical treatment, but she continued to have those repeated attacks. So the options, what you think? So again, we were discussing about the same. The options are high dose. Should you just sort of escalate the dose of steroid drops? Should you add a second line agent, for example, methotrexate? Or at least in Europe, they used to use a lot of NSAID as a sort of, in these sort of scenarios, the NSAID, I mean to say the topical NSAIDs, and they used to do some trick as well in terms of preventing some attacks, or at least reducing the severity of the attacks, if you like. So in this particular patient, she opted to go for methotrexate, and she has done extremely well. She's off steroids, didn't have further attacks. I think her next attack was after 2 years or thereabouts. So, but again, at least we did manage to prevent some of our repeated attacks of acute anterior uveitis. So, as I mentioned, where do we come into this picture? Why does this uveitis excite us? As you can know, there's a lot of very common autoimmune conditions, autoimmune systemic condition, autoimmune connective tissue diseases, and the background of patient presenting with the acute anterior uveitis. I should not have put this up there. I know you guys, rather we learn from you guys. So acute anterior uveitis, as you know, is the most common type of uveitis. Of course, infections and a lot of other neoplastic causes exist, but usually it's considered as mostly there is some underlying, some systemic autoimmune condition causing these problems. So this is the story. So this is a fairly comprehensive list of the patient presenting with acute anterior uveitis and arthritis. So this is a whole list of the patient, the underlying diagnosis, if you like, the uveitis one. And among them, all the red ones are those diagnoses where you're going to get the dual arthritis and uveitis. So there are only 2 or 3 where you're going to be no arthritis, just uveitis alone. You can imagine. So it's not just a spondyloarthritis. So there's a very big list of diagnoses where you're going to have both uveitis and arthritis. And there are only, as I mentioned, there are only 3 diagnoses where you're going to be uveitis alone. I'm talking about non-infectious uveitis, of course, not the infections. The non-infectious uveitis where you're going to be no arthritis associated. And we know that it's not that uncommon. I mean, if you look at the incidence, for example, it's more than 52. So it's a fairly common as well. So comparing, for example, what could be the underlying the diagnosis, for example, from the Middle East, from the Europe, again, the acute anterior uveitis stands at the higher side when you talk of the uveitis. And the only difference was what is the more common. In Europe, of course, what we used to see was more idiopathic causes of acute anterior uveitis. But in Turkey, for example, or at least in UAE, what we get more is the Behçet disease as the second most common cause of acute anterior uveitis. And we know very well about the impact, about the burden of the disease. I mean, this is very much comparable to diabetes and macular degeneration, for example, if you talk about in terms of the visual morbidity in the years of the vision loss in the long term. So this is not something, not that common. And of course, at the same time, the burden of disease is quite a lot. If you look at this impact, this is one of my, the Dublin colleague, Pat Murphy. So he simply looked at the same about looking at the quality of life of the patient with the uveitis versus patient not having a uveitis. I mean, you can see social functioning, pain, and the quality of life is poor of the patient with the uveitis compared to the common person. And this is a very important study. If you look at this, this is the patient with the uveitis, and in terms of following them up in the long run and to see do they get how much common is the long-term complication. So the index date is the date when the patient is going to have the first attack of uveitis. So when you follow them up, comparing to, so the blue one is the uveitis patient and the purple one are the control population. So the more long-term you're going to see those patients, the long-term complication, the hazard ratio. So this is the survival curve, if you like. Okay, and there's the hazard ratios. So what the hazard ratio is more than 5. So it means even one attack of a uveitis will lead to 5 times more common ocular complications in the long run, ocular complications. And what are those complications? And you guys, this is for us to learn, but you guys know very well. As you can see, you name it, you list it. You know, the cataract and so on. So the 57% of the patients would have long-term complications, ocular complication, even after one attack. I forgot to mention there. So this hazard ratio was with the one attack. So hazard ratio of 5.2 means 5 times more. And that is after one attack of the uveitis. And the same one, where they looked at the patient who have more what we call chronic persistent uveitis, means if the uveitis lasts more than 3 months. And you can imagine most of the people, most of the patients who would land under you or come to my care, of course, they're going to have persistent acute uveitis, right? So if we look at their hazard ratio is 8.99, means 9 times high risk of complications, ocular complications, if the uveitis persists for more than 3 months. And that is the impact of uveitis. And of course, we know about the direct and indirect burden. For example, the cost as well is more than 2 times. So the importance of collaboration, like what can we learn from each other? Why our patients, of course, can get help when they come to you guys with the uveitis. Uveitis is given such a high weightage when you talk of, for example, this is a classification criteria of spondyloarthritis. So spondyloarthritis is the second most common inflammatory arthritis. One is rheumatoid arthritis, and the other one is the spondyloarthritis, mainly where the spine is affected. And you can see it is given such high weightage of having even one attack of uveitis. So the risk of having some background of spondyloarthritis goes up. So for us, uveitis having even one attack is very, very important. And uveitis is the most common extra-articular manifestation, the most common. So around 40% of the patient with the spondyloarthritis are going to have uveitis at certain time in their lifetime. Right, and of course the prevalence varies depending upon what particular subtype of spondyloarthritis we are talking about. For example, ankylosing spondylitis, psoriatic arthritis. We know that the IBD associated or reactive, the risk is very high. So there is some individual differences when you talk of the individual diagnosis there. But if you look at the bigger group of spondyloarthritis, the risk is having uveitis is around 40%. And this is very important in the study. This is a retrospective chart review of more than 500 patients. And what we are seeing here is the green bar there. So more than 50% of the patients in this particular study, when they landed to you guys with the uveitis, they did not know that they had arthritis. So means the undiagnosed spondyloarthritis among patients with the uveitis is more than 50% in this particular cohort. And the same in the other one is nearly 400 patients, and this was 44% or thereabouts in the second one. These are two independent studies. So undiagnosed spondyloarthritis among patients presenting to you guys with the uveitis is very common. Right, and this is about the impact. I mean, of course, the same thing is the physical functioning, you know, the social functioning, and the mental health of the patient with the uveitis plus arthritis is worse compared to a patient with arthritis alone. And also it's very important, if you look at not only that they're going to have a poor quality of life, I'm talking about the patient, for example, with the uveitis along with the arthritis compared to the patient who have arthritis alone. So not only they have a poor quality of life, but they also have worse radiological functions. Means that they're going to have poor radiographic damage. They're going to have more deformities, in simple words. Right? So for us, for an arthritis patient, having a uveitis is a bad outcome. So if you look at also the patient journey, for example, the patient with the back pain, and that's where our dilemma is, because the diagnostic delay is very, very common. This is our study from Ireland. So what you'll be amazed to hear, this is the cohort of cohort 1 and cohort 2. So these were the acute anterior uveitis patient presenting to our ophthalmologist with acute anterior uveitis. And we prospectively followed them up. So you'll be amazed to hear that in the first cohort, there were 62%, and in the cohort 2, there were 72% of the patient with the uveitis who presented to our ophthalmology colleagues. They have been actually talking and going to the GPs, going to the orthopedics, going to the physiotherapists, going to the chiropractors, but nobody was actually able to make some sense that, of course, this back pain, this arthralgia with the uveitis, they should be referred to somebody for proper consultation. So it means we are not talking about an asymptomatic disease, right? We are not talking about a subclinical disease. We are talking about a young man who finally develops a uveitis and then lands to you guys. But what had happened for a number of years prior to that, nobody is actually mentioning or discussing much, and that is the dilemma. So as I mentioned there, so it's very important that we collaborate. So this was the final product of this hour. So we have managed to develop this for the first time, and so far is the only evidence base that when should you guys be referring a patient to uveitis, with the uveitis to us. So in simple, if I go through acute indolent uveitis patient, if you look at does this particular patient has uveitis or not, if there is, then definitely it's a straightforward, but if not, you need to ask, do they have the back pain or not? And you do not need to worry about what particular characteristics of the back pain you should be asking. Simply ask two things. Does this patient have chronic back pain? Means the back pain lasting more than 3 months, number one. Number two, the onset of the back pain, whether the back pain started before the age of 45 or not. Simple, these two things. If they do, then they should be getting HLA-B27, right? If the HLA-B27 is positive, then straight away rheumatologist, right? Even before reaching to a rheumatologist, you can be 97% sensitive and specific, or you should be sure, in other words, that this patient has got ankylosing spondylitis, right? So if I simplify this further, so simply in 2 steps, you should be looking at, as I said, the back pain or any other joint pains that the patient has been warning around to a general practitioner, or the patient has got HLA-B27, you should be referring to a rheumatologist. And also there's only one subset, is the patient who have psoriasis. So if you see somebody with a uveitis who does have psoriasis, forget about the HLA-B27, that patient should be referred to a rheumatologist. So as mentioned, the sensitivity, we also looked at, this is another very important study. So this is, that's how the studies literally are done in states. So literally, as you know, these are all insurance claim database. Every single thing is detailed. You simply buy the data. You just simply ask them, allow us to look into your data, and they will allow you whatever. And literally within 24 hours, you would have access to hundreds of thousands of patients. So in this particular study, what we looked at was the patient, for example, who had the uveitis, and then 6 months prior to that, we looked at all their data and looked at prospectively when would they develop spondyloarthritis, what could be the features of the patient with the uveitis. So in this particular study, nearly 50,000 patients of acute anterior uveitis, and we looked at prospective, not prospectively means looking at the retrospective data of the insurance claims, and among them, more than 1,000 patients were noted that during the follow-up they had developed spondyloarthritis, or at least they were given the diagnosis of spondyloarthritis. And surprising, there was no surprise. Only thing which really showed up was the same, the chronicity of the back pain. Number two, the age of onset of the back pain lasting means less than 45 years. And very important was the recurrent uveitis. So if any patient comes to you with the recurrent uveitis, the risk is very, very high of having underlying spondyloarthritis. So therapeutic option, if we talk of, so I mean, first line, you guys know extremely well about the topicals, and of course the implants, at least in Ireland, was very common that they used to put implants if there was some recurrent attacks of uveitis. So if you talk of, sorry, I'm just going to skip all those. So the periocular injections and the implants, it's very commonly done by you guys with wonderful results. So here where, of course, we talk about is some in terms of second line agents, how to prevent those attacks, how to be using what we, in other words, as a steroid sparing agents. So the most common one, the best data is with the methotrexate, but there are also other ones used as well. For example, if you look at this study, they looked at methotrexate and mycophenolate mofetil. There was a very borderline difference, but there was a borderline difference towards methotrexate. So some superiority of methotrexate compared to mycophenolate mofetil. Mycophenolate, as you know, is a much more costlier compared to methotrexate. So definitely our drug of choice usually is the methotrexate as the first line. Again, if you look at all the methotrexate, for example, cyclosporin, methotrexate, so fairly comparable, but the only difference that comes on the top is the mycophenolate and the methotrexate. The cyclosporin and azathioprine is a little inferior. But again, it depends on what particular patient population we are talking about. For example, if it's a young girl with a childbearing age, of course, you have to pick azathioprine or cyclosporin compared to mycophenolate or methotrexate. And naturally, those important decisions take into account looking at who we are treating. And this is the adalimumab study, only study, randomized controlled trial study, where they looked at the time to treatment failure, and there was a major difference. Rather, these two studies were stopped earlier because, of course, there was a major improvement and very clear, and that was the reason why the adalimumab, the only biologic as we speak, licensed to treat non-infectious uveitis. Infliximab has also got wonderful results. We do not have, as we speak, any randomized control trial, and the primary reason is, of course, there is no company backup because, of course, it has lost its patency, so there's not the company who is sort of sponsoring all this. But again, it's very much comparable to my eyes compared to adalimumab. First line, of course, what we do. If I'm over time, you can stop me. Because okay. So again, for the first line, again, if we are talking about a patient with the Behçet's disease, very important to understand. If any patient with the Behçet's disease come, do not waste time. That patient ideally should be started on anti-TNF as a first-line agent, plus the methotrexate as well. And in other cases, if it is not a Behçet's disease, of course, we try methotrexate first. If there's a methotrexate failure, then we talk about moving on to biologics, for example, anti-TNF agents. The only issue, of course, everything comes with some sort of the risk, and the risk in Pakistani population is the TB reactivation. In our center, we just had a study. We're going to be presenting that in abstract form as well. So we have more than 1,100 patients on anti-TNFs who we followed them up over 2 years. More than, I think, was 1,500 something patient years. Patients were followed, and what we found is the first data only from Pakistan. The TB reactivation with the infliximab and adalimumab was 600, the incidence of 627 per 100,000 patient years, which is drastically high compared to when you look at even among the other Asian populations. So in Pakistan, the TB reactivation is much, much higher. So that comes our problem because in these patients, so you should be a little bit mindful. I mean, this is JAK inhibitors, as you might have heard, so we need to be watchful that it is going to be finding its place very soon, not late. There is one phase 2, there is one phase 3 trial as we speak going on. There's a good data, but only very, very few case reports, case studies. There's only one, as I said, the phase 2, only 72 patients in that one, and very good results. But again, I think this would be a big sort of the game changer, cheap enough compared to when you talk of the other biologics, at least in Pakistan. I think we'll stop. Right, thank you. No question? Any questions? Thank you. Any questions? You want to share any? Exactly. We treat them exactly the same way, the patient with the GIA or as a patient of spondyloarthritis, and that's why we tend to have a very low threshold of a patient going on biologics when you talk of the GIA. So at least in our center, more than 60 to 70% of the patient on GIA, they're already on biologics for their arthritis. So that also prevents the uveitis as well. Because the uveitis among GIA population is very high, around 1/3 of the patient would develop uveitis, and a lot of times it's subclinical, as you know. So having biologics to control the disease better is going to help them as well.
We are very blessed with the presence of Professor Harun that we are getting our uveitis patient very well treated. We have no problem. We have thorough investigation, well treated, and then we are fully reassured that the things are okay. Thank you very much, sir.
Thank you.
And now we have time shortage, and you have a talk on the latest trend by participating.
So we have a foreign speaker, Professor Dr. George Rocha from Eye Retina Eye Institute, Brazil, and he will be discussing new concepts on venous occlusion. वो जो इनकी है या आप इनको गाइड कर देते
Hello everyone, I am George Rocha. I'm from Brazil and I'd like to thank the organized committee to invite me for this distinguished meeting. And today, I'm going to talk about new concepts on venous occlusion. I'm George Rocha. I'm from Brazil, and I'd like to thank the organized committee. I have not disclosed concerning this topic. And today, I'm going to talk about new concepts on venous occlusion. And venous occlusion. Venous occlusion was first described 150 years ago. And still today was not very clear the pathophysiology of this very important disease. It's the second most frequently vascular disease in the eye. Was not very clear the pathophysiology. Only to remember the anatomy, the vein and the artery is running close inside the optic nerve. The vein is more temporal and the artery is more nasal. In the Heidi's theory, the thrombus close the lamina cribosa can cause more severe venous occlusion. In branch vein occlusion, in 9% of the case, we have the artery crossing the vein underneath, and this compression maybe is the cause of the flow turbulence and the thrombose inside the vein. And questions. What does cause venous occlusion? Thrombus, local versus systemic factors, inflammatory factors, structural or anatomic, multifactorial, and others. Now we have the Virchow theory. If you have damage in the endothelium, you have the turbulence in the flow, and this will gonna cause the thrombosis inside the vein. In this histopathology slide, you can see that the artery and the vein is very close inside the eye. Now we're gonna go 20 years ago. We have this technique for treat venous occlusion, the neurotomy. Neurotomy was first described by Mitchell Opencart, and he published this paper with 11 consecutive cases. That the theory is release the pressure of compartment syndrome, and this can cause better venous flow. And the first paper, he had 72% of the patients gain 5 letters. After that, in this elegant editorial, Sheriff Eckhart and Kate Schuller just questions if only the vitrectomy with remove of posterior hyaluronic and remove all the cytokine like VEGF is the cause of improvement in the neurotomy. And remove all the cytokine like VEGF is the cause of improvement in the neurotomy. After that, we have VEGF and steroids.
Very well done, good presentation, but we will not have first, second, third position because that is reserved for residents only. So we have all the speakers. We will give certificates and हाँ जी हैं पेन है ठीक है ओके सो आई विल कॉल सर आप आ जाइए जावेद साहब मजीद साहब आ सो डॉक्टर हमजा नदीम डॉक्टर अनम यूसुफ डॉक्टर फातिमा महमूद अब्दुल्ला मदन साहब नहीं मैं कुछ नहीं बस हाँ चलो बुला लेते हैं हाँ जी बस ये हाँ अच्छा कौन देगा तो जो चौधरी साहब दे देंगे चलो so Javed Chaudhary Sahab will give a bouquet to Professor Majid Sahab, the host. Yes.
नेक्स्ट क्लिनिकल मीटिंग का कह रहे अनाउंस कर
हाँ जी कब है the next clinical meeting is on 14th October May Hospital and I would suggest Professor Majid Saab to upload this excellent video on YouTube. You say the fantastic video of cataract surgery, sir, it should be on the web. And Sugar-Xanthoma elastica or infectious disease, get publications out of these cases. It should be in the literature. Thank you very much. So, Professor Javed Chaudhary sir will have vote of thanks.
अस्सलाम वालेकुम। मुझे पता है कि इस वक्त आप सबको बहुत जल्दी जाने की I'm really grateful and it is always pleasure to visit FMH, but not in love to FMH, rather love to Professor Majid. He is my dear friend and my classmate, so it is always pleasure to visit this department. I can't thank enough our senior members, especially Professor Mohammad Salim Akhtar साहब, जो हमेशा हर मीटिंग में तशरीफ लाते हैं, उनके लिए एक दो जोरदार तालियां दीजिए। I'm grateful to our very senior member, Dr. Kamaledi साहब, and प्रोफेसर मियां मोहम्मद शफीक साहब, प्रिंसिपल LMDC, और प्रिंसिपल साहब बहुत शुक्रिया आपके आने का कि आप अपने बिजी शेड्यूल से टाइम निकाल के लाए, बहुत शुक्रिया आपका। I'm grateful to Brigadier Shakur साहब, Dr. Kashif Iqbal, and all of you and future doctors. I'm thankful to you for joining us and attending this clinical meeting. I hope it might be useful for you as well. And अब मैं खाने के दरमियान और बाकी चीजों के दरमियान वक्फा नहीं बनना चाहता। Thanks a lot, Fatima Memorial Hospital Department, Fatima, Anam, or Abdullah Mazhar. Thank you very much for your excellent presentation. My advice is consider other conditions as well. And thank you very much. Thanks a lot.
बहुत शुक्रिया सबका। It was a wonderful afternoon. Now let's move for the food. It is being served on first floor in our OSCE hall. All of them to proceed. Nobody will be leaving that session. Thank you. ना उतर नहीं जाना बस।